We're going to go ahead and get started, everyone. If you need permission to record, Pat will grant those, and we'll also be recording this and send this to our media partners. But thanks for joining us. I'm Erin Goff, Media Relations Manager for Intermountain Healthcare, coming to you live from the Transformation Center on the Intermountain Medical Center campus. Thank you for those who are joining us and our media partners who are joining us via Zoom. Just a quick reminder to the media, you know how this works. Put your questions in chat. And if you're joining us on Facebook, you can put your questions in the comment section. We'll start out with just a quick update on the numbers. Yesterday, Utah reported a record number of hospitalizations yesterday. 776 people are hospitalized. That's the highest number we've seen throughout the whole pandemic. Today, we're joined by Dr. Wing Province, emergency physician and Intermountain Park City Hospital medical director. Dr. Province, thanks for joining us.
Hey, Erin, thanks for having me.
You bet. Let's just start out talking about what you're seeing there at the Park City Hospital and Summit County. When it comes to COVID, what are you seeing?
Yeah, when it comes to COVID, we're still seeing it. You know, we started out in Utah as a place where really the pandemic started, and it continues here. You know, we have a unique population here in Summit County in that we have a lot of folks who come and visit us from out of country, out of state, and those folks are certainly having COVID and bringing it here to our community, and we have it here in our community as well. I'd say of our visits, about 20 to 25% of them are COVID patients, and many of those are able to go home. Some of those are admitted, and many of those require being transferred to one of our COVID hubs throughout the state. So we continue to see it on top of everything else we see in the emergency department this time of year, like ski accidents and snowboarding accidents, those sorts of things, but certainly keeping us on our toes, Erin.
Now, normally this time of year is Sundance Film Festival, and all those live events had to be canceled. Has that changed anything what you're seeing at the hospital?
You know, I think so. You know, the years that we have had the years that we have had Sundance, we certainly see an uptick in all of our ED visits. There's certainly a lot more injuries and just a lot more people in town coming in with whatever injuries or sicknesses they may have. But, you know, last year, not having COVID or having COVID, but not having the Sundance Film Festival, I think certainly helped out, and I think this year as well. I remember in 2020, COVID hit in March. The Sundance Film Festival was in February, and you know, brought people from all over the country here, and that's soon thereafter is when we started to see a surge here in Park City. So the fact that the Sundance folks put people's lives and health over profits really meant a lot to this community. That we hope and look forward to having them back in the future, because we do love having Sundance and all that comes with it here in Park City.
Great. So as Senior Medical Director for Emergency Medicine and Trauma for Intermountain Healthcare, what can you tell us about system-wide what we're seeing when it comes to COVID?
Yeah, I think those same numbers mirror a lot of what we're seeing throughout the system, whether it's in the rural facilities or in our big cities. We're still seeing, you know, a quarter to a third of our patients are COVID positive and coming in for COVID issues. A lot of folks are actually coming in because of such a shortage in testing. We're actually seeing people who are willing to pay for an ER or an emergency department visit just to get a COVID test, even though they really don't have a lot of symptoms or severe disease. They're still coming in just to get tested. And you know, that's certainly making it difficult for us to take care of the patients who are the sickest and who really need to be there. But we understand the shortage is out there, and so people want to come and get tested. Along with that, we are seeing a lot of people who are coming and hoping they can get certain therapeutics and medicines for COVID. And you know, as we can probably get to in a little bit, not everybody qualifies for that. So, and then we have the people who truly do need to be there, who have medical emergencies. So we're seeing it all over the state of Utah and Idaho.
So just in the last few days, we've been starting to hear about the Omicron subvariant, BA2. What can you tell us about that?
Yeah, it's interesting how fast this virus can mutate. So it's not a separate virus than the Omicron. It's just a subvariant. All I can say is that we have researchers who are monitoring it. I think it's been found in about 50 countries, according to the CDC. We don't know much about it. We have 54 cases that we've seen here in the United States. The WHO is asking for countries to investigate it worldwide. And in particular, what we worry about with any kind of variant or subvariant is, can it be detected with our tests and how deadly is it? And we still don't have answers as far as that goes yet. But as soon as we get more information, then we will certainly be sharing with the public.
So let's play what if I just got tested positive for COVID-19? What should I do? I know a lot of people are confused about where they should go, and what they should do. What's your advice?
Yeah, it's a good question. I actually get that a lot from friends and family, texts in the middle of the night from friends on the East Coast and on the West Coast. So one bit of advice I've been giving everyone is, if you don't already have a pulse oximeter, one of those little cubes that you can put on your finger that tells you your oxygen level and your heart rate, I would recommend going out and getting one. But before you ever have any COVID symptoms, because to answer your question, Aaron, once you get it, what should you do? Well, I would recommend having that on hand to test your oxygen levels. Really, the people who need to come into the emergency department are those who have severe disease. And of course, no one's going to know that at home on their own. That's what we're here for. But having a pulse oximeter helps us differentiate those who have severe disease versus more of a mild or moderate case. And so if your oxygen levels are less than 90%, then I would say you should come to an emergency department or call 911. For most people who are in overall good health, I would say just to isolate at home, take good care of yourself, and that includes staying hydrated, taking Tylenol or ibuprofen when you have fevers or body aches, and really importantly, just don't go out, because when you go out with COVID, you continue this pandemic, but when you stay at home, you stop the spread, and that's really important. If you're wanting to get monoclonal antibodies, currently the emergency department is not the place for it. You may ask or scratch your head and ask why. And the reason is that, particularly previously when there were monoclonal antibodies available in the emergency departments, I should clarify. But the difference is that with Omicron, of those 4 or 5 monoclonal antibodies that we had available that worked against the Delta variant and all the previous variants, only one of them, called sotrovimab, actually works on the Omicron variant. And so because of that, you can imagine there's a shortage of that medicine because there's such a high demand for it. And as a result of that, we have to give it to the most ill. So those would be anybody listening who's immunocompromised. So if you are taking any kind of immunosuppressing drugs because you're a transplant recipient, you're on chemotherapy because you have cancer, or you have some sort of autoimmune disease, or you have a chronic disease like heart, lung, kidney, or liver disease, then you should call your doctor or go see a healthcare physician immediately, or come to the emergency department. The warning signs I would really like to get out there for people to pay attention to: if you're having difficulty breathing, if you're having difficulty staying awake, and that's not normal for you, if you're pale or your lips are blue, call 911 or go to the nearest emergency department. That would be a sign that your oxygen levels are low, and then you need to come in right away.
Are there other options for people like Connect Care or those kind of things?
Yeah, I would say for patients who are interested in going to other places, where should I go? I mentioned the emergency department, but if you don't have a primary care doctor, Connect Care, which is the ability to FaceTime with a physician or an APP, another provider, gives you that option to talk to somebody over the phone and to give you medical advice and guide you to where you should go. So Connect Care is a nice place to go, especially because it's a free visit with that provider if they end up guiding you to an emergency department or an urgent care. Also in Connect Care, they can connect you. If you qualify, they can write you a prescription for the pill that's out to treat COVID-19 called Paxlovid. Again, that's in limited supply, but if you qualify for it, a kinetic care physician or a provider could give you that, could give you a prescription for that so you can have access to it. Urgent care is also an option. However, I would say just keep in mind those warning signs that I mentioned, because if you have those, if you go to an urgent care, they're just going to refer you to an emergency department. I will say though, if you are interested in monoclonal antibodies, it is the urgent cares where you can receive them. However, urgent care, you cannot just walk in and put your hand down on the counter and say, I'd like an order of monoclonal antibodies, because they're not going to be able to give it to you. You have to have those scheduled ahead of time by appointment. And so the urgent cares are useful for that. But if you have severe disease or signs of severe disease, like I mentioned, you want to go to an emergency department.
Okay, we have quite a few questions in the chat, but before we get to that, I wanted to ask you about the blood shortage. Little off topic, but it all impacts what's going on in our emergency rooms. What can you tell us about the national blood shortage?
These are actually tied together, the pandemic and the blood shortage, Aaron, and maybe not for the reasons most people are thinking. So it's a blood shortage. I should qualify by saying not just unique to Utah or to Idaho or to Intermountain Healthcare, but this is a nationwide shortage. Because of the pandemic, a lot of the Red Cross caregivers that take care of our blood and not only take blood from donors and then process it, they have such a shortage of their own caregivers that we just don't have enough Red Cross caregivers to actually process the blood. We have lots of donors out there. Donors aren't the issue. We're very fortunate to live here in Utah, where we have a population of people who are really wanting to help out and provide blood if needed. So it's not a shortage of donors. It's just a matter of not having enough people to process the blood once you obtain it. And really, the Red Cross and maybe ARUP are the only organizations here in Utah who can do that for us. So as much as Intermountain would like to offer those services, or the University of Utah or any of the other health systems here in the state, we just have such a high bar and such a high standard in the United States for filtering the blood and making sure that it's free of any kind of communicable diseases. Those high standards we just don't have the ability to do in any hospital. And so we really rely on the Red Cross or other kinds of agencies that do that. And they're just at a shortage now. So because of that, we're at an extreme shortage throughout the state of Utah. That impacts us because in the emergency department, we do more than just take care of COVID patients. We see people who come in who have gastrointestinal bleeding, people who are trauma victims. And there's a lot of reasons why people are losing blood or come in anemic. And the emergency department's where you can receive that blood. But currently, there's such a shortage that we're really having to go to cautionary measures to make sure that the blood is going to those who need it the most.
Thank you. Let's go to the chat with a couple of our questions. First off is from Jamie Lampros with Standard Examiner. She asks, about COVID's deadly effects manifesting long after some patients leave the hospital. There's a new study that points to the pandemic's great aftermath. Hospitalized patients who survived at least a week after being discharged were more than twice as likely to die or be admitted again within months.
Yes, that's exactly right. And that's the challenge that we're facing. So not only have we heard about long COVID, which are those patients who go home after a long stay in the hospital with COVID and then deal with the after effects for weeks and months, you do see folks who do bounce back. And a lot of that has to do with the fact that it's a disease that oftentimes early on, patients seem to be doing well, and then their body reacts differently to it later on in the course of the disease. And it's not so much that the virus itself that's really causing the deaths, but it's the way that every person's body reacts to it. Some people have a really high inflammatory response to it. Sometimes that doesn't manifest for 10 to 14 days after the symptoms began, or even after an admission to the hospital. And so we are seeing a lot of readmissions because of the very fluid nature of this disease and just how everybody does react very differently to it. I've had family members all come in. I've seen a whole family come in where one individual has only the respiratory issues, the spouse has only the GI issues, and their college-age kid only has a loss of taste and smell. And the college kid gets to go home, but the two parents get admitted with completely different courses of disease. So to your point, yes, we're seeing a lot of that, and that's contributing to the really high hospitalization rate that we're seeing right now.
Kind of related to that question from Chris Reed, St. George News, he asked you to talk about the people who may not show up in the hospitalization numbers. Are they going home with few problems?
Yeah, that's a great question, Chris. And it's an important one because a lot of people, I think, pay attention to just the number of positive tests, and really the true marker of how severe this disease is in hospitalizations. I've been hearing people say, you know, Omicron is less severe, and therefore we don't need to take it as serious. I've heard a lot of parents say, I just want to get it and get it over with. My family can have the antibodies and just go on with their lives. But the reality is, look at our hospitalizations. They're still really, really high. And so, yes, there are a lot of people who do come in who may not qualify for hospitalization. In other words, their oxygen levels are fine, and so they do go home. But they do, many of them do come back later when their oxygen levels drop, or they just deal with the long-term effects of COVID. They're exhausted. You know, what we see here in Park City, as I imagine you see down there in St. George, Chris, is we have a lot of active people who live here and who really enjoy going out and skiing, running, jogging, swimming, doing all that they do here, and they just can't do it anymore. I was talking to an individual just on Sunday who used to do all of that, and he says he got COVID, and now he has put strategically stools in his home about every 12 feet away from each other, because he knows that's about when he's going to get short of breath and lightheaded, and so he stops, catches his breath, and that he does just to get to the bathroom. And this was somebody who's young and very active previously before contracting COVID. So certainly a hit on quality of life for those who are suffering. That's why I recommend to parents, don't just go get Omicron to get it over with, because you may not be over with it as soon as you think.
Great. Next question from Ariel Harrison, who asked, they had got word from a father who regularly gets his kids tested for COVID because they've been so sick a lot recently. The pediatrician told them there's an illness going around that's similar to COVID and the flu, but it's neither. This might be, I don't know what you know about that, but can you answer? That's her question.
No, it's a great question. I've got 5 kids myself, Ariel, and so I'm always worried about what kinds of bugs they're bringing home that aren't COVID. You know, we're testing them as well. And there does seem to be other viruses going around, people who come in and just don't test positive for the flu, influenza, or for COVID. You know, every year before 2020, and even now is what I'm getting at. There are hundreds of viruses that are out there that can cause cold-like symptoms. And in fact, the coronavirus was one of those that we used to just dismiss regularly. COVID-19 or SARS-CoV-2 is just one of many coronaviruses. But there's other out there, parainfluenza, for example, RSV, that are certainly spreading throughout our communities because we're just not wearing masks as commonly as we did in 2020 and 2021. So the only way to know, Ariel, what those viruses are would be to go to a hospital and get a very expensive test where they could test you for a whole panel of viruses. The reason we don't do those, though, is because there's not really anything to do. There's no treatments out there because those viruses aren't deadly. And there's really only treatments that are developed for deadly viruses. And so as a result of that, a lot of times we give you the unsatisfying answer of we just don't know. But if you were to pay a really expensive test, we could tell you, but it wouldn't really change what we would do. All I would say, though, is all that more speaks for the reason of why we should continue to wear masks whenever we are in public places, because it can not only stop the spread of COVID-19 and influenza, but all these other viruses. And with all these other viruses causing similar symptoms, it leads to more testing and a lot more worry. So that's just a plug for wearing masks when you are in public.
Thanks, Dr. Province. Next question from Lisa Riley Roche with the Desert News. She asked, Summit County saw Omicron surge before much of the rest of the state. When is the latest surge expected to peak there? You know, get out your magic ball and figure that out. And what impact has the lifting the mask mandate had on cases?
Hey, Lisa, thanks for asking that question close to home for me. What we started to see is that Summit County right now is the only county in Utah where we started to see numbers of COVID cases going down or declining. All the other counties in the state of Utah are seeing an incline, and we're very fortunate here that they're declining. Now, it could be a couple of reasons. Number one, it could be that we had that mask requirement in public places for a few weeks. And that also happened around the time or coincided with Martin Luther King weekend when we have a lot of tourists. So I would say that we could probably attribute a piece of that decline to having the mask requirement here. But I think the other piece of it is, or the other factor to consider is just such a limited number of tests that are available out there. It could be that people are just stopping testing, and as a result, we're seeing a decline in cases in Summit County. So it's really hard to tell. But you know, as you very well know, we have the mask mandate. We are seeing a decline in cases here, so it's hard not to ignore that fact.
Great. From Aaron Alberti with the Tribune, are the people who go to the ER for a COVID test included in the state's hospitalization numbers if they aren't admitted?
For hospitalizations, I see what you're saying. That's a good question, Aaron. No, the hospitalizations are only those who end up going from the emergency department to either a medical ward bed or to an ICU bed. So very good question.
Great, thanks for clearing that up. From Facebook, we have a question. If someone is still testing positive weeks after the first positive test, do they still need to quarantine?
It's a great question. It reminds me of the beginning of the pandemic. I don't know if you all remember, we had the first citizen in Utah came in, I believe it was from a cruise, and they lived in St. George, and we were keeping them in the hospital isolated until they had a negative test, and they were testing positive for weeks. And that was before we really knew much about this disease. Now I can say with confidence that what you need to do, even if you're still having positive tests, really what you need to look for is a decline in your symptoms. So if you're no longer having a fever and you don't have to take Tylenol or ibuprofen to break the fever, or if you're noticing that your symptoms have essentially disappeared, or you're just left with a cough, which is probably the most common symptom that people have for weeks after testing positive for COVID, then I would say use your symptoms more as your guide and follow the public health guidelines as outlined by the CDC to determine when it's safe to go out. So right now, the most current guidelines are, as we all have been hearing, 5 days after a positive test, unless you're still symptomatic or still have a fever, then you need to isolate for 10 days. And then you can go out once you're no longer having a fever or your symptoms have improved. A very good question.
Great. From Erin Alberti again, she wants to know what precautions you're having to take to preserve the blood supply, and are people not getting blood who normally would?
It's a great question. We are going to give blood to patients who are critically ill and who need it, and we're not going to withhold blood from those patients who need it most. I think the paradigm switch that we're doing right now, well, I'll just say what the old paradigm was. In the old paradigm, if someone had certain numbers of blood counts, we would just automatically transfuse them with blood. And we would try to hold off on doing any procedures if we could. Now what we're doing is we're reversing that. To preserve the blood that we have, we're now taking patients to get those procedures done to prevent any bleeding if at all possible. Additionally, we're using other therapies that we have available to stop bleeding immediately if we can. But you know, there are patients who are going to need blood, and we're not going to withhold it from them if they need it. That said, if we get into a situation where there's such a shortage throughout the state of Utah and throughout the Intermountain system, where, well, I guess I should say, what we're trying to avoid by doing that is by having these strategies where we take patients to go to surgery or have a procedure done to prevent further bleeding. We're doing that to preserve our blood so that we never get into the situation where we call crisis standards of care, where you have two patients who need blood and only limited supply, and we have to choose between one or the other. I'm very happy to report that we're not at that state yet, and that's why we are doing everything that we're doing now to ensure that we never get to that place.
follow-up question from Aaron wanting to know if you could describe some of the kinds of procedures that would preempt a blood transfusion, just for example.
Yeah, an example would be somebody who has an upper gastrointestinal bleed or a lower gastrointestinal bleed. In those kinds of patients, sometimes the bleed will stop on its own if you just provide the patient with enough blood, if it's not a very bad bleed. But now what we do, it's a procedure called an endoscopy, either an upper endoscopy if the source of the bleeding is the small intestine or above, or a lower endoscopy, or otherwise known as a colonoscopy, if the source of bleeding is below the small intestine. Now we're a lot more quick to take patients to do those procedures than we were before, and that's just because of the risks of running out of blood.
And then a follow-up question from Jamie Lampros. She wants to know, is long haul the same as chronic fatigue?
You know, that's a great question. I would say there's a bit of overlap, but they're not one and the same. So long haulers is a term that's been created to describe the period of time after someone survives COVID and they deal with the lingering symptoms. There are a lot of symptoms that can come from COVID on the long-term basis. One of those is chronic fatigue. Others are, as you've probably heard, loss of taste and smell, chronic cough. Chronic fatigue is a different entity that can be caused by COVID-19, but it can also be caused by other issues or other conditions. And so there are people who have chronic fatigue who never had COVID. And chronic fatigue actually existed prior to COVID. So COVID is just one way that you can get that entity, but not the only way.
Great. I don't see any more questions here, but I just wanted to, all of a sudden Aaron popped in here. Wasn't Intermountain occasionally delaying procedures though? Do hospitals have the staff to beeline to surgical procedures to avoid blood transfusion?
Yeah, excellent question. We do have the staff to take care of those people who would need those procedures. And you're right, there was a time when we were delaying procedures just because we didn't have the capacity for those patients. In other words, we had so many COVID patients in the hospital that we just couldn't do other elective or routine surgeries, or essentially elective or routine surgeries that people were scheduled for. And so we delayed those until we had the capacity. For somebody who has an emergent bleed, emergent meaning they have a condition that could potentially be life-threatening, we make capacity, we have capacity for those people, and we would never delay that kind of a procedure.
Thank you for that update there. I just, before we wrap up, I just wanted to throw out, you went to New York and you were there in the thick of things when this first started. Any lessons learned, and did you ever have any idea that we'd still be here talking about COVID?
Oh, that's a great question, Aaron. I remember when I got back from New York, I was talking to some of the leaders here in our hospital, and I told them that I think this might go on even beyond the summer. And one lady looked at me and she said, "I sure hope you're wrong, Wing, because I just don't see this being going beyond the winter." And here we are 2 years later. One part of my experience that I was really impressed with New York was how a whole city, a very diverse city, banded together to reduce the number of cases that they had there. I marveled at the diversity that was there, whether it's religious diversity, cultural diversity, the color of people's skin, their backgrounds, everybody. New York, as you all know, is a very diverse place, and yet despite that diversity, the whole city came together, putting all those differences aside, and did everything that they needed to get this pandemic under control. I think here we are 2 years later, and we have done that for a long time, and now people are getting fatigued. I overheard somebody the other day talking about how they just wish this would be over with, and how the government would just let it be over with, and how the media would let this be over with, and how they wish healthcare people would just let go of it. And by the way, I don't think these two individuals knew I was a physician, but they were very public in what they were saying. And I just want to say to all those listening, I want you to know that we doctors and nurses and respiratory therapists and technicians and everybody who works in the hospital, we don't want this either. we wish it were over with too. We actually think it could have been over with a long time ago, had proper public health measures been taken by the public. We're just as tired of this as you are. We'd love to go back to our normal lives. We'd love to not go to work, and every time we go, worry about being exposed to a disease that we could bring home and, you know, infect our families with. We want it to be over with too. But the reality is that we are still dealing with this. We have record high hospitalizations, and just looking at the records now, or at the numbers now, worldwide we've had more than 5.6 million deaths. Here in the United States, we've had over 875,000 deaths here in the United States. Just to put that in perspective, 875,000 deaths and counting from a disease, compared to 290,000 from World War II, 200,000 from the Civil War. You look at, if you combine all the wars that we've had since World War II, and we still have not had as many deaths in those wars as we've had from this war that we're currently fighting against COVID-19. And this is a unique war that is preventable in the sense that it just takes each one of us to put aside our own needs, to put the needs of others ahead of our own, to go and to wear a mask when you're in public, to get vaccinated and boosted. It's a disease and a pandemic that could have ended long ago if we could just put the needs of others ahead of our own. But in as much as we put our own needs ahead of others, and we put our own priorities ahead of those around us, then we're going to continue to have this pandemic, a pandemic not only of a virus, but I think a pandemic of personal moral character. So I'm very optimistic, though. I've seen it in my neighbors. I've seen it in my community. I've seen it in New York. I've seen it all over the country. I know we can do it. It's part of our American values to put the needs of others ahead of our own. That is who we are here in the United States, and I'm optimistic that we can rally together as a community and as a country to do that. And I tell you what, I look forward to it, because I'd love to get back to doing other things in emergency medicine than just taking care of COVID. But until then, I myself, with all my colleagues, we will happily take care of anybody who comes into our emergency departments.
I think that's a great place to stop, and I appreciate you taking the time, Dr. Province. We will download this and send the recording out to our media friends, and again, appreciate media joining us and helping us get this message out. We couldn't do this without you, and really appreciate the media and all that they do for us. And then for our Spanish-speaking media, we will give us 5 minutes to reset, and you've got the link for that. We will jump over to that and do a Spanish version of this news conference. Thanks again, everyone, for joining us.